So we've heard here today that the healthcare systems need to change for financial reasons, for quality reasons, for access reasons, and for that we need to do more care at home. We also heard from Inger that person-centered care is a way of doing this. And what I will tell you now is that there needs to be changes also in the context and in the environmental factors to be able to work with person-centered care in an effective way. And these changes, we are calling them enablers. If you look up enablers in the Cambridge dictionary, you will see something that makes it possible for a particular thing to happen. And if you try to break that down, you can start to look what particular thing need to happen. And that particular thing is, of course, person-centered care. And that is person-centered care to have it long-lasting and sustainable, and also realizing all the potential benefits from person-centered care in terms of quality and cost savings. We also heard from Håkan Hedman about home dialysis, how that really could help both to improve the quality and save the costs. So what's the something? The something is our enablers. And what we mean by that is that it is environmental or contextual factors that will facilitate person-centered care. We have in two multinational, multidisciplinary EU-funded collaborations, WeCare and this one, CostCares, we have identified 5 categories of these enablers that will help to work in a person-centered way, and I will go through them. The 5 groups or 5 categories of enablers that we have identified is technology or IT, quality measures, structure, organization, incentives, drivers, and contracts. This looks like 5 distinct groups, but they actually are all linked together. For example, it's impossible to do a good contract without having a good quality measure and agreeing what kind of incentives you should have in the contract. In the same way, it's difficult to have a technology without having a good quality measure and seeing that it's actually delivering what it should do. So they are all linked, these enablers. Let's start with the first one. And the first one is the technology or IT that could facilitate working in a person-centered way. And this is technology from a very broad perspective. I give you a few examples here. Technology to facilitate communication. For example, between the patient's home and the primary care unit. But it could also be to help facilitate communication in the direct meeting between the healthcare professional and the patient. And that is, for example, to understand what are the treatment options for me and what are the consequences if I choose a particular treatment option. It could also be tools to facilitate documentation. In this meeting that I just described, you need to take notes and document it. Ideally, you would like to spend as little time as possible on that, and maybe you could have voice recognition, maybe linked to artificial intelligence to do this capture of the record. It's technology for self-monitoring. There are multiple wearable devices that can measure different things and help you to understand if your health is starting to deteriorate and you need to do something about it. It's also technology to facilitate practical participation in your own treatment. And as we heard Håkan talk about before, it could be dialysis equipment, for example, that can be used by laymen, not needing to be experts in their own homes, and many, many more things. These are just a few examples. The second enabler is quality measures. What quality measures do we need to know that we actually work in a person-centered way? Of course, the pure medical outcome is very, very important, but it's not enough to know the blood pressure, to know the cholesterol, to know the mortality, and so on. So what other measures are important to understand quality? I'll give you just a few examples. Self-efficacy or independence is often very important for many of us and is a quality measure, as I see it. Ability to continue your life as before continue with the job, continue with your hobbies and so on, is also important for many of us. Own experience of your health, family relations and priorities. For example, is it more important to be able to attend your daughter's graduation than having your chemotherapy that particular week? Maybe it's better to postpone it 1 or 2 weeks so you can do that. Understanding symptoms and this concept of patient-reported outcome is also very important quality measure. The third enabler is structure and organization that will facilitate person-centered care. And this involves structure and organization at multiple different levels. It involves the macro level, which is the national level. How do we organize healthcare? How do we interact between hospitals and primary care units, homes, and so on? But it's also links between healthcare system and other sectors in society, social care, unemployment insurance, sick pay, etc. It's also structured at the meso level. How do we organize the hospitals and the primary care units in a way so we can work in a person-centered way? It's also a structure and organization at the micro level, at the patient, the person level. How do we get access to healthcare? How do we make sure that our personal medical records and own data is the property of ourselves? The fourth enabler is incentives and drivers that are important for us to work in a person-centered way. And this again includes incentives at multiple levels. It includes incentives at the macro level, meaning how hospitals are incentivized by payers. We know today that it could be that you are paid for the profile of the patients in your hospital area. You could be paid for what kind of procedures you are using, and all other different systems. It's a number of different potential systems are being used. But what system is the best one for working in a person-centered way? It is also incentives at the meso level. How do hospitals control and allocate their budgets to different departments? But it's also, of course, incentives at the personal level, at the micro level. How do healthcare professionals, how are they motivated to work with person-centered care? How patients are motivated to participate in their own care? How do we motivate relatives and so on? It includes incentives of different kinds. It's not only monetary incentives that you get money for doing something, but it also includes a lot of non-monetary incentives. For example, motivation of being able to do good to others. It's a strong incentive for most of us. A motivation of having enough time to do their professional skills and to use their professional skills is important also for healthcare professionals and many other types of incentives. So the last enabler is contracting, and again this is contracting at multiple different levels. It could be contracting between hospitals and payers to secure quality and quantity to society. It could be clear agreements within healthcare units to ensure that the units are working in a qualitative and effective way. But it's also agreements between patients and persons and the caregivers written up in health plans to ensure obligations and commitments and expectations and that they are really met. So in summary, we know the group of enablers that we need to change to get sustainable, high-quality healthcare and work in a person-centered way. We now need to find out the exact nature of these enablers and how we can combine them to get an effective healthcare system. This will be the next step, but how will we do it? Changing the healthcare system is like eating an elephant. Do we have time to eat the elephant in small bites? Or must we take bold steps together to get a paradigm shift in the healthcare? I think it's your choice.